our website. Okay, again, my name is Diane. Welcome to our webinar. I'm Executive Director of Partners for Pediatric Vision, and I would like to introduce my team. We have Tori Schladen, who is the founder and Director of Special Populations. Tori, you want to say hello?
Hi, everybody. Welcome. Thanks for joining us.
And then we also have Helen, who has been doing our communications, and she's responsible for our social media and all the really great and creative posts that she's been doing. So thank you, Helen, for everything. And we have Mackenzie, who I think a lot of you guys already know. And she's one of our bilingual family specialists and provides direct care to our families. And I think I just heard Ethan there as well. And she has a 3-year-old. So welcome.
Hello.
Okay, great. So again, thank you for participating in it. And we have Dr. Teresa Rosales, who is going to be speaking on understanding your child's diagnosis or visual impairment. And Dr. Rosales, she is a native California. She grew up in East San Francisco in the Bay Area. She got her BS in biology from Stanford and her medical degree from UCLA. I know that we have some UCLA people here as well. She did her ophthalmology residency at Harbor UCLA Medical Center, a fellowship in pediatric ophthalmology at Jill Stein Institute at UCLA. She was in private practice in pediatric ophthalmology in Long Beach for almost 40 years, but I don't believe that it's been 40 years. You don't live a day over 29. And she just retired 3 years ago. But she's still working at Harbor UCLA as a clinical professor teaching ophthalmology residents. And so before I hand it off to her, I just want to just let everyone know this webinar is an educational program focusing on pediatric eye conditions for parents, teachers, and other professionals working with young children with visual impairments. The topics presented should not be considered a medical or educational consultant, but just information to help you better understand your child's eye condition or pediatric eye conditions and how to assist them. In terms of questions, Dr. Rosales has a lot of material that she is going to go over and review. Please put questions in the chat. She did get some pre-submitted questions that she will be answering. If she can't get to everything, and I'm not sure if she will be able to, please reach out to your family specialist for further information. If there's something that we can't, if we can't answer, we'll definitely reach out to Dr. Rosales. And if I can have everyone mute, and that way there's no interruptions for Dr. Rosales' talk, that would be great. And then I turn it over to Dr. Rosales. Thank you for being here.
Thank you very much. I'm looking forward to doing this. So we're going to be talking today about some general topics, but based on some of the questions that have come in. We'll start just with some basic information about why your child should have pediatric vision exams, whether it's with your pediatrician or your optometrist or ophthalmologist. Checking their eyes early, especially when they have some systemic conditions, will help determine whether there's any other problems going on. And even if we can't get their vision perfect with glasses, often glasses are very helpful in improving what vision the child does have. Children, as they grow, their prescription changes and their visual exams may change. So ongoing exams are really important. If there's any family history of eye problems, then of course it's important to have the children examined at an earlier age. Just briefly, the difference between ophthalmologist and optometrist. The ophthalmologist is a medical doctor who does general eye exams as well as surgery. They've gone to college and then medical school, then done 3 or 4 years of postgraduate training in ophthalmology. And for myself as a pediatric ophthalmologist, that means I did an additional year of training in pediatric ophthalmology. Optometrists are doctors of optometry. They have additional training after college at optometry school. They do eye exams, prescribe glasses, contact lenses, and can prescribe eye drops and medication for a number of different eye problems. And then there are optometrists who specialize in low vision therapy or treatment and exam and evaluations. And I believe there are a couple of low vision optometrists who are affiliated with this program as well. I wanted to, and this is a little bit of a busy slide, but people have asked specific questions about problems within the eye. And I just wanted to make sure that you have a general understanding of what's going on in terms of the different anatomy. So this is a cross section of the eye, starting from the front here at the cornea. The cornea is clear. Behind that is a space that's filled with fluid. And behind that space is the colored part of the eye, which is the iris. The pupil is actually an opening in the center of the iris. Behind the pupil is the lens. So there was a question in the correspondence that came in about congenital cataracts. This is where a cataract would be, whether it's in a child or in an adult. It would be an opacity here in the lens. I'm not going to talk too much about cataracts today, however. Behind the lens is the clear gel. It's supposed to be clear. And in the back of the eye is the retina. That's the lining all the way around the back of the eye. At the very back of the eye is the optic nerve. And we had some questions about the optic nerve that I'll touch on later. On the outside of the eye, these lines represent the muscles. And there are 6 extraocular muscles that move the eye up and down and side to side. So if your child has strabismus, where the eye is turning in or out and has to have eye muscle surgery, they don't open up the eye and they don't take the eye out. They operate on the muscles here on the outside of the eye. So that's just a really quick overview of the different parts of the eye, because we've had questions on colobomas, which are problems with the retina. And we've had questions about cataract and a couple other questions. So here's an example of a coloboma. A coloboma is just a defect. It's a problem that occurs in we call it the embryogenesis, when the eye is developing in utero before the child's born. It starts off as like a cup, and those edges of that cup have to come together. And they come together in a seam that runs from the optic nerve all the way along, all the way along the back of the retina and up to the pupil, through the iris. And so you can have defects just in the iris. They call this a keyhole pupil, and you can see it looks like a keyhole right there. And you can have a defect all the way along the retina and even up involving the optic nerve. So this is a photograph, and it looks rather confusing, but here's the optic nerve right here, that little tiny area. All of this is a defect where something happened in the process of the eye developing, and this whole area didn't close the way it's supposed to. So we're looking actually through where the retina should be. We're actually looking at this part of the eye, which is called the sclera. That's the white part of the eye. So somebody had written asking about colobomas and vision, and depending on the severity of the coloboma will determine what kind of vision problems a child may have. If it's just in the iris right here, causing this funny looking pupil, it's not going to cause a vision or visual acuity problem at all. There might be increased glare because the pupil can't get small like it does for the rest of us. There are cosmetic contact lenses that can improve the cosmetic appearance of this, but for the most part, if it's just in the iris, that's not a significant problem. It can cause some, like I said, some glare or light sensitivity. If, excuse me, if the coloboma is significant like this, then it's probably affecting the macula. The macula is your area of central vision. you need a functioning macula in order to have normal vision, in order to have 20/20 vision. And so if, as in this case, if the defect involves this area, the area of your central vision, then the patient or the child is not going to have normal vision. But if the defect is somewhere along here, along the retina, and the macula is not involved, they can have normal vision, even with a coloboma. So it depends on the nature of the defect and how much of the retina is involved. So here's some more information about colobomas. In terms of accommodations, again, it depends on the nature of the coloboma, but you want to do things to reduce the glare if the pupil is involved, such as sunglasses or visors or wearing hats outdoors. And using magnification, again, depending on how much of the posterior retina is involved. So this is a normal retina. This is what it's supposed to look like. So when the eye doctor looks into a patient's eyes with the flashlight, this is the view that they're going to see. They're going to see the normal optic nerve right here, these normal blood vessels, and here's the macula. That's the area of central vision. There are a lot of different disorders that we could talk about that affect the back of the eye in different ways, but this is what it's supposed to look like. One of the questions that came in was asking about optic nerve hypoplasia. That would be when the optic nerve is smaller than normal. So instead of having this normal appearance, it can be anywhere to actually having no optic nerve to just a reduced size. And let's see. So optic nerve hypoplasia, they may or may not have decreased visual acuity. It can be in one or both eyes, depending on how significant the small size is. The patient could have nystagmus. If there's reduced vision, they could have strabismus, which is when the eyes are not straight, either going in or going out, or one eye could be higher than the other. In both coloboma and optic nerve hypoplasia, there can be reductions in the visual field. And again, it all depends on the degree of severity. So if it's a very small optic nerve, then it might not have a visual field on that side of the eye that's affected. And obviously visual perception is going to be impaired. So in terms of accommodations, of course, it always depends on how involved the disparity is. But whenever there's a decrease in vision, one of the things that we highly recommend is protective glasses, safety glasses to protect the good eye from any injury. The list here includes high illumination, high contrast, enlarged print, avoiding visual clutter, avoiding busy backgrounds, which is a similar kind of thing. So again, all of this depends on the severity of the involvement and whether it's one or both eyes. There is a syndrome that includes optic nerve hypoplasia and other systemic problems. That's a very specific type of problem. We've had several questions about albinism. So albinism is a hereditary disorder. It's recessive, which means that both parents have to carry the gene. And it can be what we call oculocutaneous, meaning that both the eye and the skin is involved, or it can just be the eye that's involved. In oculocutaneous albinism, it's pretty obvious the child has very fair skin, blonde or white hair, The eyelashes are white. The iris is light colored. And it can actually have what's called transillumination of the iris, where when you shine a flashlight into the eye, for example, if you take photographs, a flash photograph, you'll see the light reflected back through the iris as well. So the iris doesn't have the normal melanin to block the reflection. And so you see like albino rabbits, their eyes are pink, and the light is reflected from the back of the retina, and it's not blocked by any pigment in the iris. These children with albinism, generally as toddlers, you may not be able to tell that they have reduced vision, because for most toddlers, their world is up close. But as the kids get older, parents start to notice that they can't see far away. They may have nystagmus, that's the wiggling movement of the eyes. If their vision is significantly decreased, they'll be sensitive to the light, that's photophobia. They'll have sensitivity to glare. They may or may not have a high refractive error, but most kids with albinism do need glasses. Now, the glasses aren't going to cure the problem or give them normal vision. The hope is to improve what vision they do have. The central scotomas, that means that they may have a blind spot in the center of their vision. The reason for that, I want to go back to this diagram. Albinism is a problem of the cones, and the cones in our eye, we have cones and rods that work to process vision and send that information to the brain. The cones are centered around the macula. And again, I said that that's where your central vision takes place. So if you have a defect in your cones, you're going to have decreased central vision. And if it's severe, you could have a scotoma there or a blind spot there. In contrast, the rods are more in the periphery, and they're more important in night vision. So people with retinitis pigmentosa, for example, where that's more of a rod problem, a rod dystrophy, they'll have problems with their night vision and peripheral vision to start with. And then in some cases it's progressive, and they can end up having significant visual loss. So albinism is a cone deficiency. So they will have color vision defects, and it affects their central vision more significantly. You can have muscle imbalance or strabismus, and not everybody has reduced depth perception. So accommodations for albinism include magnification as needed. Not every child with albinism needs Braille or needs large print, but definitely for distance. So close viewing, their near vision is better than their distance vision. A lot of kids with albinism may have nystagmus for distance, but it's dampened or not as prominent or noticeable if they're looking at something up close. High contrast materials. They'll need to use sunglasses, a hat with a visor outdoors, and often indoors as well, just to prevent the glare from the lighting overhead. Lighting behind is better for them. So sitting in the classroom, it's better if they can have their back to the window, because that helps to reduce the glare. And again, depending on the severity of the disease and the amount of decreased vision, they may need line markers, may need accommodations with test taking and that sort of thing. Most kids with albinism will not have much better than 2200 vision, which means your teenagers are not going to be able to get their driver's license, most likely. And that's a tough conversation that you'll have to have with the kids as they get older. But in the classroom, they will need accommodations in terms of seeing things at a distance, because their distance vision is decreased. So both, anytime when there's a significant decrease in vision, these children may have nystagmus. Again, nystagmus is an involuntary shaking of the eyes. It can be primary or secondary. So the nystagmus may be the underlying problem, and there may be nothing else going on with the eyes themselves, and that's primary nystagmus. And with nystagmus, if your eyes are constantly moving, then you can't have 20/20 vision because the target's moving all the time. But on the disorders we've been talking about right now, nystagmus is secondary to the decreased vision. So children with albinism, congenital cataracts, colobomas, optic nerve hypoplasia, all of those kids can have nystagmus as a secondary cause if their vision is severely decreased. Depending on the cause of the nystagmus, if it's secondary to decreased vision, surgery is usually not indicated because we can't solve the underlying problem, which is causing the wiggling in the first place. If it's primary nystagmus, sometimes surgery is an option, especially if there's a significant head turn or face turn. Some children with nystagmus will turn their face to look in a certain direction in order to see more clearly, because they may have what's called a null point, where the eye's not wiggling as much in one direction. So they'll tilt or turn or chin down or chin up, adopting some kind of a face turn in order to see more clearly. So sometimes surgery can be done to try to move that quiet point, the null point, to the straight ahead position. It's not 100% successful, and it's more cosmetic than anything else. But if they have a severe face turn, then it's certainly something to consider. Okay, I wanted to cover. There were some questions about decreased vision after having had congenital cataract surgery. And the question was, the child had 2200 vision, and the parent wanted to know what to expect in terms of that kind of vision, and would that get better or worse? And the parent also had questions about when to do secondary surgery to put in an intraocular lens. So with children with congenital cataracts, if they're significant as an infant, then the surgery is done as soon as possible. It's critical to have a clear visual image in the first 3 to 6 months of life. So the surgery is done sooner rather than later. Waiting is not a good choice with congenital cataracts. And traditionally, we have not put intraocular lenses, the implant lenses, into babies and have treated them with glasses or contact lenses until later on when they're older, and then do a secondary implant. And that was the question one parent sent in. That is changing over time, and there are situations where intraocular lenses are put in primarily, but usually still not in under 6 months of age. And I think in this particular case, the surgery was done much earlier than that. So the question was, when should a secondary implant be put in? If the child is tolerating the contact lenses and the glasses, then generally the recommendation is to wait on secondary surgery. The challenge is trying to determine what power of lens to put in the eye, because we know that as kids grow, their prescription changes. And that's true for all kids who might need glasses. As they get older, their eye gets a little bit larger and it changes in prescription. And So if you can wait until the child's 8 to 10 or 12, that would be wonderful. But a lot of times, keeping contact lenses on a small child can be a major issue. It's hard to keep them in, they're expensive. The kids rub their eyes, the lens falls out, they lose their contacts. It can be a real problem. And so then it's better to get some kind of prescription in, whether it's glasses or contacts. And if they don't tolerate that, then maybe it's time for the secondary surgery to put the lens in. So there's no absolute age to do the secondary surgery. It really depends on each child and how they're tolerating the treatment. Then the other question was about if you have 2200 vision, what does that mean going forward in terms of prognosis for the child? And this is true for the child with albinism, congenital cataracts, or any other problems in the eyes. 2200 vision means that you can only see the second line on the eye chart. The big E is 2400, the next row is 2200. That's not good enough to get your driver's license, I'm afraid. In the state of California, you need 20/40 vision or better in one eye. So most kids with severe vision impairment, if it's in both eyes, are not going to be able to get their driver's license. So that's one issue. They will need accommodations in the classroom. As I said, kids with albinism often have better vision at near and may not need large print or braille for near tasks, but they'll need accommodations for distance. Kids with other defects like a coloboma or optic nerve hypoplasia, their vision is going to be equally impaired, whether it's distance or near, and will need the kinds of accommodations that we've talked about already. Okay, there was another question. I'm going to skip amblyopia for right now, and I'm going to skip strabismus. But there was another question about high myopia. Myopia is nearsightedness. Nearsighted means you can see up close better than you can far away. This is the most common reason why people in the world are wearing glasses. There's actually a concern that myopia is getting more and more and more common. And the thought is that it's from all the screen time that we're doing, the near tasks, the reading. And there have been pretty compelling studies in Japan and in Australia looking at kids from rural areas compared to urban areas, and kids who are outdoors more, or those who are in the classroom or looking at near targets all the time. And it looks pretty convincing that we need to limit our screen time, which I'm sure you're hearing from your pediatricians already. That's been hard to do during COVID when they weren't able to get out and play. The studies from Australia also indicate that being outdoors and being out in the sunshine is a positive factor that helps reduce the progression of myopia. Part of the problem is that myopia is hereditary. It seems to be autosomal dominant. So if your parents are nearsighted, your kids are going to be nearsighted as well. But it also occurs in certain syndromes. It's more common in preemies, especially the really small preemies. And myopia gets worse as you grow. I don't have a diagram of it, but in myopia, the image that we're looking at focuses in front of the retina because the eye is effectively too large. So you can't bring things into focus at distance. As you bring the target closer, then it can now focus on the back of the retina the way it's supposed to. High myopia is considered over a -6. And I mean, some kids have huge prescriptions, and they have what we call Coke bottle glasses because the lenses are so thick. There are some things that you can do to try to reduce the progression of the nearsightedness. And I talked about reducing the screen time, encouraging being outdoors and playing. But also there's some medication that's being used now. It's low dose atropine. Atropine is a drop that dilates the pupil, but secondarily, we found that kids who were on atropine for other reasons had a slowing of the progression of the myopia. So I've started using that, and now it's pretty standard of care to start using low dose atropine eye drops to slow down the progression of the disease. Doesn't work for everybody, but when it does work, it's wonderful because then we don't have these kids with really high prescriptions. But nonetheless, there are still kids who, for whatever reason, have really high prescriptions, and they are at increased risk for other problems, most specifically retinal detachment. The reason the prescription is high is because the eye is effectively too large. And as the eye continues to get larger, there's stretching on the inside on that retina, and breaks can start to occur in the lining of the retina. Let's go back and we'll look at that diagram again. Let's look at the one from the side. So if you're nearsighted and your eye is getting bigger and bigger, this retina isn't really growing as much, and it starts to stretch, usually right around the front here where it's attached to the line, where it's attached to the lining of the back of the eye. And you can start getting little breaks or tears in here. You've probably heard the description or the phrase flashes and floaters. And your doctor may have said, if you start seeing new onset of flashes and floaters, you need to come in right away. Well, the flashing light is when the clear part in here, the vitreous gel, is pulling, or when the retina is pulling and tugging, that causes flashing lights. And the floaters are red blood cells, because if there's a break across a blood vessel, it's going to start to bleed, and that bleeding will be here inside the eye, and it'll cause dark spots. The patient will see dark spots or floaters inside the eye. So patients with high myopia are at increased risk for developing a retinal detachment, and those are the symptoms of it. The other symptom of a retinal detachment is if it starts to separate, not just getting those little breaks and tears, but starting to separate, then the description is a curtain coming down over your vision. And that's because the retina is coming off of the back of the eye, and you're starting to lose vision with that separation. Any of those symptoms would mean you need to get in to see the ophthalmologist right away, because that needs to be treated with surgery. Let's see, the other risk with high myopia is there's a higher risk of glaucoma as well. And glaucoma is pressure inside the eye that can cause long-standing problems. Okay, I think we're going to skip all of these other things for today. We still have some time if there are specific questions. So Tori, if any questions have come in.
Yes, there is a question from Lori. Her question, Dr. Rosales, is how long can you wait to place an intraocular lens before you begin to have issues with eye pressure?
Okay, putting in the intraocular lens, the increased pressure can be caused by the intraocular lens sometimes, not very commonly, but it can happen. So I'm not sure, I'm guessing this is somebody who's had congenital cataract surgery. And now you're trying to decide when to put a lens in rather than using contacts or glasses. And I don't think there's a time frame as to when to put that in, and I don't think there's a relationship between glaucoma and the cataract or the intraocular lens. What you may be referring to is that kids who've had congenital cataracts and have had surgery do have a higher risk over time of developing glaucoma. And as I mentioned earlier, glaucoma is increased pressure developing inside the eye. That pressure can cause damage to the optic nerve, and you could start to lose vision in the visual field. So the children who've had cataract surgery, the younger the age, and especially if you put an intraocular lens in early, there is a higher risk of glaucoma. But just kids in general who've had congenital cataracts and have had congenital cataract surgery do have a higher risk of glaucoma. So there may be a relationship between the intraocular lens and the glaucoma. It seems more likely that it's whatever caused the congenital cataracts. There may be other functional problems in the eye that can lead later on to glaucoma. So yes, there's a higher incidence of glaucoma in kids with cataract surgery, but I'm not sure that there's a relationship with the timing of the intraocular lens with that. I hope that answers your question.
We do have lots of parents here, so yeah, please send us your questions. Here we go. Another question, Dr. Rosales, do you recommend protective eyewear for kids who wear contact lenses when they go to school?
Okay. Not well, for contact lenses in general, no, they don't usually need protective glasses or safety glasses. But if they're wearing contacts because they have decreased vision, then yes, they should be wearing safety glasses. And they're not, big safety goggles. They can be any pair of properly fitting glasses that has the polycarbonate lenses. That's what safety glasses are. So they can be your sports goggles, or they can just be regular glasses as long as they have the polycarbonate lenses. And I think in the state of California, all children's glasses have to have polycarbonate lenses. So that, but just because they're wearing contacts doesn't necessarily mean that they need to wear safety glasses. Now, if this is an infant or a toddler who's wearing contacts, maybe putting safety glasses on will help keep their hands away from their eyes so they won't rub the lens out. That is a possibility. But just in general, no, we don't usually recommend safety glasses on top of contacts.
There's another question from Lori. By what age should strabismus surgery be completed?
Okay, that's a good question. We didn't talk about strabismus today. That's another whole hour conversation by itself. And all of these problems depend on the underlying problem. If the strabismus surgery is purely cosmetic, if they have very poor vision in one eye that can't be improved, say, for example, a coloboma in one eye, or the optic nerve hypoplasia, or trauma or something that's causing poor vision in one eye, then the timing of the strabismus surgery is more, how bad is it? Is the child being teased in school? Is it bothering the caregivers? If the child's not bothered by it and his peers aren't teasing him about it, then there's no rush to do strabismus surgery. Because if there's poor vision in one eye that can't be improved, then the strabismus is probably going to recur over time. And so there's no rush to do the first surgery. On the other hand, if you're trying to get both eyes straight because there's vision in both eyes and you want the child to be using both eyes together, then there is an urgency and sooner is better. So it really depends on what the underlying problem is. If you're patching the good eye, trying to improve the vision in the eye that's turning, then once the vision's as good as it's going to get or equal in both eyes, then that's when you should do the surgery. So depending on vision and age and what your ultimate goal is, determines when to do the surgery. In general, sooner is better. You want to get those eyes straight as soon as possible if there's a chance of using both eyes together.
Allison has a question. Can you speak to any research or thoughts related to the causes of optic nerve hypoplasia?
And before we go on, and before you answer that, I think Aria had a question about what is the differences between like optic nerve atrophy and optic nerve hypoplasia and stuff like that. So that might be a good preference before you get into that one.
Okay, so optic nerve atrophy is from some kind of damage to the optic nerve. It can be from compression, from a tumor in the brain, for example, something causing some kind of injury to the optic nerve, cortical, or they've changed the name, cerebral, CVI, cerebral visual impairment. It's changed names 3 times since I started practice. So that can cause optic nerve atrophy. Glaucoma can cause optic atrophy. Trauma that causes damage to the optic nerve can cause atrophy. So there are lots of different things that can cause optic nerve atrophy, but it's from damage to the eye or to the nerve, and it doesn't recover. Once the optic nerve is severely damaged like that, we don't have any treatment. There's no eye transplant or nerve transplant at this stage to help that. Optic nerve hypoplasia is a congenital defect. You're born with it. And as to the causes, I did not do my homework to look that up. There is a disorder called septo-optic dysplasia, and that's a disorder. There are problems in the brain as well as with the optic nerve, and that's a birth or developmental problem. Other causes of optic nerve hypoplasia, the patients that I remember having seen, it was just random. We didn't come up with any cause. I don't know if any of the other professionals have any input on that as to the causes of optic nerve hypoplasia.
Well, I know some of our families, and of course we followed Dr. Borchard's studies at Children's Hospital Los Angeles, but it's been kind of inconclusive. I think initially they were looking at environmental factors, and there's a lot of folks who've been involved in that study over the years, but at this point, I haven't heard of them pinpointing, as you said, specific as a cause for optic nerve hypoplasia. So, but if anybody needs more information or is curious about those studies, let us know and we can give you some referrals and information about that study going on. Okay. We do have some more questions. Let's see. How does vision improve? Looks like her child has bilateral cataracts, or had them at 5 to 6 weeks. Now he or she almost 3. Currently 2200. How does the vision acuity improve? Sounds like the doctors are saying that there's lots of room for improvement, but how does it go from 2200 to 2020?
Okay, well, part of it is that most 3-year-olds can't read the eye chart. So the eye charts that we use, depending on their cooperation, the picture chart only goes to 2030. But again, a 2-year-old or a 3-year-old, we're mostly testing by their behavior whether they can fix and follow a target, whether they'll look at the toys at the end of the room. If the vision really is 2200, if the patient is cooperative and old enough to read the chart and that's the best they can do, I would not be terribly optimistic that they would eventually be 20/20. Our vision in the research lab in a normal, healthy newborn, the vision is 2200 approximately. By the time a child's a year old, again, in the research lab, when they're doing the preferential looking, the feeling is that by a year, most kids have 20/20 vision, but we can't test them. We can't measure that in a doctor's office. So I'm not sure, again, not knowing this particular patient, I can't really address why the doctor is optimistic that the vision will improve to 20/20. But maybe it's because they're just testing the vision based on behavior, and everything else being equal, are hopeful that the vision will improve to 20/20. Having said that, kids with congenital cataracts don't usually get 20/20 vision. They can get close though. I've seen kids with 20/40 vision, and that doesn't qualify for visually impaired. So I agree with it that there's room for improvement and there's room for hope. Can they get 20/20? I don't know. Without knowing the particular circumstances, it's hard to comment on that.
There's another question about vision delays. So maybe in general, if you're told that your child's vision is delayed, what is recommended or what are ways to improve their vision?
That's probably more in your field than in mine. I usually tell the parents to use, because usually if the vision's delayed, often the child is developmentally delayed. But not always. But I usually would tell the parents to use toys with lights or sound, to encourage them that it's not cheating. If the toy has lights or sound and they're looking in that direction because they hear the noise, you're trying to stimulate their vision and encourage them to look and to track and follow things. Do you have other suggestions on other things that you're doing with kids who are visually delayed? I mean, I'm guessing like cerebral cortical or cerebral visual impairment. You just working on stimulating their vision.
A lot of times what we'll do is black background, unclutter things, give the time, lots of time for the child just to look at things, and just kind of go slowly depending on where the child's at. But yeah, high contrast lighted toys. Okay. I always tell parents, if they seem to be having difficulty looking at something, simplify it, make it easier to see.
And take time, yeah.
And take time.
And I think for our little ones, there's a lot of ways we can incorporate and encourage vision just in a family's everyday life, basically. So really capitalizing on those times during the day, if the child's at home or after school, whenever it is, that we can encourage vision. And, there's lots of ways to do that. That's very individualized. So yeah, we do that kind of by family and by child, but yeah, we want to make it as easy as possible and, to enhance the vision.
Okay.
Yes.
There was a question that I think got skipped, Tori. It was by Lori. If a child has damage to parts of the eye as a result of an inflammatory process, is vision loss ever reversible?
Okay, good question. Yes. The short answer is yes. Longer answer is it depends. Depends on what's causing the problem and how much damage. Inflammation in the eye is called uveitis, and it can be in the front part. When I showed on the diagram, like from the iris forward, that's called anterior uveitis. It can be in just behind the iris, and that's intermediate or intermediary uveitis, and then uveitis or inflammation in the back of the eyes, posterior uveitis. And those can all be caused by different issues. Sometimes it's from infection, sometimes it's from arthritis, inflammatory diseases. Usually the treatment is steroids. And if steroids aren't helping, then there are other medications, Remicade, methotrexate. There are things that the rheumatologist will recommend, and those treatments can reduce the inflammation. So if you can get the inflammation under control, then yes, the vision can improve. There are side effects, of course, to everything. Everything has risks and benefits, and you have to weigh that with every child and with whatever the problem is. That's the underlying problem. But yes, the vision definitely can improve. And now with newer medications, there's a lot better results than there used to be. When we only had steroids, the steroids can cause glaucoma and they can cause cataracts. So the side effects from the steroids created other problems. But with these other anti-inflammatory medications, usually administered by a rheumatologist, we're seeing much better control of the inflammation and less damage to the eye. So yes, the vision can improve.
There's two questions. One's probably a shorter answer than the other, so I'll tell you both. Lori's asking about your professional opinion of the accuracy of teller cards. And then there's another question about vision therapy and what is that?
Okay.
that question that we get frequently.
All right. So yeah, well, let's end with the vision therapy one. Okay. So the teller cards, they're teller acuity cards. They're not usually used in your average ophthalmologist's office. I don't know about optometrists, but generally it's a research tool. And they're looking at, they have lines on them with different spacing in between. And you present the cards to the child through a apparatus, and you're looking at looking at the difference in the grading and the size of the grading, which card the child looks at. The theory is that they're going to look at the card that is more interesting to them. It takes somebody who's really skilled in doing this test to be able to notice a difference in the child's behavior. So it really requires a cooperative infant or child. In the right hands, it's pretty accurate. But I don't know if optometrists do this, but certainly I don't know any ophthalmologist that uses teller cards. It's pretty time consuming to do that with a small child. In the studies that are done, then they seem to have good results. And I've seen videos showing it being done in practice, and looks like that it's fairly accurate, that the child will look at the more interesting card and that helps them figure out what the vision is. But it's not a very practical test. The other question is about vision therapy. We could talk a long time about this. Vision therapy is usually done by developmental optometrists. When it's used, most ophthalmologists are not big fans of vision therapy, and that's putting it politely. Because there are times when we feel that it's being used for issues that are not really, so there's no research supporting the benefits of using vision therapy. So when it's used for learning disabilities, there really doesn't appear to be substantial research showing that this is beneficial. And the ophthalmologist's point of view is that if the child has a learning disability, then they need remediation through an educational approach. If vision therapy is being used to improve control, for example, if a child has an intermittent outward drift of the eyes or exotropia, vision therapy can work on improving their convergence or moving their eyes together or straighten them out, and it can improve their control. So in that setting, vision therapy is a useful tool. I've also seen it be very helpful in patients whose eyes cross and we're trying to get them to straighten out if it's intermittent. Vision therapy can be useful for, I think maybe it's kind of a term that we're using when we have children with cerebral visual impairment. We're doing therapy to improve their attention, their perception, and that sort of thing. So when it's used for reading problems, ophthalmologists in general don't feel that that's an appropriate use of vision therapy. When it's used to improve other aspects of vision, then we're in agreement. Okay, hopefully one more question came in. Do we have time?
I think.
Okay.
What are your suggestions or recommendations for a child with optic nerve atrophy since birth?
Okay. So again, it depends. Is it both eyes or one eye? If it's one eye, then, bilateral. She just answered that question. Okay. That's a tough one. Again, it depends on the age of the child, the cause of the atrophy, the severity of the vision loss. So if you're dealing with an infant, you need to find out what's causing the problem. Why does the child have optic atrophy? Is it something that's treatable? If not, then you need to assess what the vision is and then go from there in terms of trying to teach the child to use whatever vision they have available. If it's an older child, then you can test a little better and figure out what the visual acuity is, and then determine what accommodations need to be made, again, depending on the visual acuity. Usually glasses are not helpful. So that's a tough one. Without knowing more detail about the particular child, it's hard to be specific about what recommendations I would do.
Okay, great. Thank you. It's 5 o'clock, but perfect timing. Again, thank you so much for your time, Dr. Rosales. I wrote down some things that I've learned, so thank you. Even though I've been sitting on eye exams for how many years, I always learn something new and things kind of click. And so we appreciate your time. We will put the recording on our website. Give us a little bit of time to get it. Helen, I'm sure, will do her magic and be able to post it for us. But we want to thank everyone for joining us. If you have any further questions, please feel free to reach out to your family specialist, Mackenzie, me, Tori, Rosanna. Rosanna should be back next week or so. And if there's something that we cannot answer, we will definitely reach out to Dr. Rosales for clarification. Mm-hmm. But we all of us would be happy to have a more thorough conversation with you about your specifics for your child. Okay. Great. Well, thank you so much. Tori just put our phone number in the chat. Again, thank you for joining us, and you guys have a wonderful evening.
All right. Thank you.
Thanks.
Bye.